Hello, welcome to this program related to levodopa therapy in Parkinson's, wearing off and management, particularly of wearing off. My name is Werner Poewe. I'm a clinical neurologist and director of the Department of Neurology at Innsbruck Medical University in Austria. With me today to discuss are Professor Angelo Antonini.
Hello.
He's also professor of neurology and is the director of the Parkinson department at the Institute of Neurology in San Camillo, Venice, and also professor at the Department of Neurosciences at Padova University in Italy. Hello, Angelo.
Hello.
And Professor Olivier Rascol,
Hello.
who is a neurologist and pharmacologist. He's professor of clinical pharmacology at the University Hospital in Toulouse, France. Thank you for being here, Olivier.
Welcome.
We want to speak about Parkinson's disease treatment problems, particularly today, and the learning objectives for our audience in this activity today are to, of course, understand the role of levodopa, which is still the gold standard in Parkinson's, but also to understand the clinical spectrum and also the mechanisms behind motor complications, in particular wearing off, and then to understand the strategies we have in treating this, and particularly, again, focusing on the role of COMT inhibition. And before we start discussing these items, I should maybe give a brief introduction into Parkinson's disease. It's the second most common neurodegenerative disorder, and the cardinal features by which we define Parkinson's disease, of course, today are still the motor symptoms, the cardinal motor features, bradykinesia, rigidity, tremor, and they very much are driven by dopamine depletion in the nigrostriatal dopamine projection and causing the classical symptoms on the motor side. But Parkinson's disease has a prominent non-motor element, and we will talk a little bit about this in relation to wearing off. Dopamine depletion in the striatum is progressive over years, and unfortunately to date we have no drugs yet to slow this process and modify disease course in that regard, although, as we will learn today, we have powerful tools to treat the dopaminergic problem of Parkinson's disease. Levodopa is the gold standard, although an old drug. Still, it has the most pronounced symptomatic effect on motor symptoms among all the agents we have, but a majority of patients will experience motor complications, in particular motor response oscillations, with wearing off within as little, sometimes as 1.5 or 2 years. More and more patients will get these issues when we treat them for prolonged periods of time, and we will be talking about some of the efficacious treatments for this, including COMT inhibitors. Angelo, you have of course been very much involved with studying wearing off in large groups of patients, also the time course when it first occurs, the prevalence. You've been involved in trying to improve recognition. Maybe you could, for our audience, briefly summarize the clinical features of wearing off and how we best recognize it.
Thank you, Werner. I think this is a very important aspect of the disease, and it is one of the critical issues that we face in the clinic when we are discussing with patients about motor manifestations. After the first few years of treatment, people with Parkinson start losing the benefit, the more stable benefit, and they start manifesting during the day periods of reappearance of the motor disability, which may be associated many times to non-motor manifestations. One of the problems is, of course, that if people with Parkinson and their treating neurologists are familiar with the tremor, the rigidity, the bradykinesia, they may not be that much familiar with the fact that in some cases it is not only the tremor as a manifestation of reduced effectiveness or duration of efficacy of the drug, but also manifestations like anxiety, depression, fatigue, pain, or if this is occurring during the night, early awakenings with perception of stiffness, difficulties in rotating in bed, or even early morning dystonic cramps. These manifestations are indeed all belonging to the spectrum of wearing off, but unfortunately, particularly during the first few years, are poorly recognized. And the studies that we have been conducting in very large patient cohorts in Italy, utilizing questionnaires and asking the physicians and asking the patients about these manifestations, have clearly shown that during the first 5 to 6 years, a large proportion of people with Parkinson do manifest conditions like increased anxiety, depression, fatigue in the afternoon hours, or they had difficulties at sleep. But this is not recognized by the neurologists. And I think one of the objectives really of any educational activity would be to improve awareness from the neurology and for the patients about the existence of these features that are really having an impact on quality of life. It could be potentially corrected by medication adjustments.
I think it's important that you're making this point that oftentimes doctors and patients are not immediately aware of wearing off being the cause of particularly non-motor symptoms that you've been describing, and that recognizing these phenomena early is obviously important for their treatment. Another aspect I think which is very important obviously for treatment of anything is to understand the mechanisms that underlie the phenomenon. And this is again something that, Olivier, you've been very instrumental in working on as a clinical pharmacologist and neurologist. Maybe you could summarize for us a little bit why does wearing off with levodopa therapy develop?
Yeah, and it's a very important question. It's not entirely clearly elucidated. There are many mechanisms. Some are involving mechanism out of the brain. Some are considered to be dysfunction within the brain. But the concept is that if dopamine is missing in the stratum, which is causing the abnormal motor signal for people to move, we could replace or enhance the dopamine transmission at its level. And it was recognized 60 years ago that the production of dopamine is depending on the metabolism of precursors, and one of these is levodopa. And levodopa can be decarboxylated to produce dopamine, so that's a very simplistic approach, but straightforward. Now, our understanding of the physiology of dopamine within the synapse in the brain is not entirely clear, but we believe that there is a need for a stable, sustained dopamine transmission so that the system is functioning smoothly without oscillation. And it is probable that because of the property of levodopa, pharmacokinetic and pharmacodynamic also, at the periphery and in the central of the brain, this is not perfectly achieved. For example, levodopa, when it is administered orally, is only absorbed to pass into the blood and then cross the blood-brain barrier to reach the brain in the duodenum, in the upper part of the intestine. And before that step, when the pills of levodopa are swollen, there is the gut obstacle. And as long as the levodopa, which has been swollen, is not reaching the duodenum, then there is no absorption. And in a number of patients, there are, hours sometimes before the gut is emptying. So that's one aspect. And this is explained also the impact of food on the effect and the response to levodopa. The second thing is that levodopa is metabolized also at the periphery by different enzymes, and one of them is called the COMT, which is methylating levodopa into methyl-dopa, which is not active. So as long as levodopa at the periphery is metabolized into this methyl-dopa, then this is lost for function. And this is one of the reasons why came the concept that blocking this enzyme at the periphery is going to be having an impact on the response, because it will reduce the elimination rate of levodopa and then prolong its action and allow more levodopa to reach the brain. Now, another aspect is that once levodopa has penetrated into the brain and is supposed to be transformed into dopamine, there are very complex mechanisms that are illustrated, for example, by the fact that the relationship between the plasma level and hopefully the cerebral level of levodopa and the response are not completely correlated. And if you give to a patient with Parkinson's disease an acute dose of levodopa, in fact, you get two responses. One is known as the short duration response, which means that rapidly the benefit on motor functioning is observed and is cleared off, as levodopa elimination half-life is about 90 minutes. But in patients, even after having stopped levodopa and after 2 hours, there is still a residual effect benefit which can last for days. And the difference between this short and long duration response might also explain, while at the level of a single individual, depending on the importance of one of these two responses and the change over time, the duration of the benefit is modified.
I think this is something we have learned in also clinical trials, that it takes a while after the initial worsening, after withdrawing levodopa, before the full bottom line is reached. And you indicated that with progressive degeneration and loss of buffering time, buffering capacity rather, of dopaminergic neurons, remaining terminals in the brain, we will see more and more of these oscillations in plasma levels that are due to the short half-life translate into the brain. I think that is also believed to be an important factor in the development of the other problem, dyskinesias.
Yes. In fact, what we understand is that this change in the stimulation of the dopamine receptors, because of the disappearance or reduction of the long duration response, is generating abnormal plasticity at the level of the dopamine synapse. And in cascade, after the receptors, the intracellular message is also modified. And this is why the on-off problem is occurring, and certainly also the dyskinesia, which is a kind of a mirror phenomenon, and why patients are oscillating after a few years between periods of Parkinsonism, where they are slow and stiff and shaking, and periods when they are on, but frequently at the price of an abnormal motor signal which generates choreic movements.
You had mentioned that an important peripheral factor for the contraction of duration of action of levodopa over the course of treatment is the breakdown, the short half-life of levodopa, and that there are possibilities by enzyme blockers to intervene. And you had mentioned COMT inhibition in particular as a peripheral mode of changing this pharmacokinetic profile. Could you tell the audience a little bit about the current role of COMT inhibitors, what we have and what we know about their not only mechanism of action but also their clinical efficacy?
Sure. So in fact, blocking this enzyme, COMT, may have two impacts. One is at the peripheral level, because levodopa is metabolized by this enzyme, but it could also be conceived that at the central level, dopamine being also metabolized by the same enzyme, you could have two targets. At the moment, there are 3 COMT inhibitors which are available on the market. Historically, the second generation, we call them, calling entacapone and tolcapone, have demonstrated that blocking this enzyme, this translates into improving the bioavailability of levodopa as measured by plasma concentration, and improving then also the amount of levodopa which is reaching the brain, which is what we are targeting at. There is one difference between entacapone and tolcapone, which is that entacapone is not crossing the blood-brain barrier, so it's only blocking or supposed to block the COMT at the periphery, while tolcapone is also crossing the blood-brain barrier and may have this second effect at the central level. The reality in terms of clinical importance of the difference is not obvious, and we believe that the most important mechanism is the impact at the periphery. And the third generation of COMT inhibitors, which is opicapone, is targeting mainly also at this peripheral mechanism.
Yes.
In terms of response, we will discuss this later on, how this translates into improving on or reducing time spent off.
Right. That is, of course, what we want to achieve for our patients by optimizing the peripheral kinetics with more sustained levels, longer half-lives, greater areas under the curve, not necessarily increasing the peaks of concentrations, but reducing the oscillation, which, of course, is an enhancement of dopaminergic drug delivery. And there are sometimes issues with that to observe as well. We've been mentioning dyskinesia as being a side effect. Angelo, what do we need to consider with respect to using COMT adjunction in Parkinson's in fluctuators who have dyskinesias?
I think this is an issue which occasionally we face anytime we increase dopaminergic stimulation in Parkinson's disease. Of course, we know that typically fluctuation, so the wearing off phenomena, anticipates a bit the occurrence of dyskinesias. And to manage wearing off, we need to optimize or extend the efficacy of levodopa, making levodopa more available for dopamine production. And this, as we just discussed, can occur relatively easily by adding a COMT inhibitor. And I think nowadays with opicapone is quite simple, because you just need to add one tablet in the evening, and this was not the case in the past when we had the previous generation COMT inhibitors, where you had to either change all doses of levodopa into a combination therapy or add maybe 3 times a day tolcapone. So I think this has become relatively easy to introduce in the clinical practice, but the relatively easy use, of course, must make people aware of the fact that if you boost dopaminergic stimulation, in some cases you may trigger the involuntary movements, or you might see an aggravation of involuntary movements that were already present, maybe in a milder form. Now,
but
here,
that can usually be managed, can't
yeah,
it?
I mean, I would like really to enforce the concept that this is nothing to be scared about. I think these days we will all agree that having troublesome dyskinesia is relatively uncommon in Parkinson's disease, and the percentage of people with troublesome dyskinesia is not big. And the majority of cases, dyskinesias, if they appear, can be quite mild. And for this, I suggest that once you add a opicapone, for instance, to the treatment regimen, you don't change the amount of levodopa you're administering, and you observe what happens to the patient for the next 3-4 weeks. In case there is an increase of dyskinesias and this is perceived by the patient as troublesome, then of course we can reduce slightly the dose of each individual dose of levodopa, trying to bring it down a bit. Or if patients are on a combination therapy, in some cases you may have to lower also dopamine agonist dose, but in general I would suggest to reduce the dose of each individual administration of levodopa. One thing we should not do is to for instance, abolish one of the doses and then make the interval broader, because that might lead to the appearance of off-related phenomena.
I think what you're saying really makes clear the point that with advanced Parkinson's in terms of motor complications being present, fluctuations and dyskinesias, there are several components to the drug regimen one has to keep an eye on, and as you indicated, these are patients who are often not only on levodopa. When you add the COMT inhibitor, they may have an MAO-B inhibitor on board, they may have a dopamine agonist on board, and one may, in case of emerging or worsening dyskinesias, downregulate any of those components, which in the programs we've all been involved in the clinical trial programs of COMT inhibitors, have usually led to a balanced outcome with no worsening of dyskinesias following these reductions and adaptations. Which brings me to clinical trial programs and opicapone, which is the newest addition to the list of COMT inhibitors we have available. And you've already indicated, both of you, we have a once daily drug here that is easy to handle from that point of view. What else can we say, Olivier? You've been very much involved in the trials about the efficacy and also safety of opicapone in this population of patients with levodopa treatment and fluctuations.
Well, the studies have been conducted in this population of patients with somehow advanced stage of the disease after 5 to 7 years, when they are considered to suffer from about 5 to 6 hours of time off during the day. So the idea to document the effect of a COMT inhibitor like opicapone is following a relatively standard process and method, which is to enroll these people into a design which is parallel group randomized controlled study. Half of the patients or a proportion of the patients are randomized to the active treatment, and another part of the patients are randomized to a comparator, which may be inactive like placebo, or which might be a drug that has been already known for improving such patients. And in the opicapone development program, in one of the study, the comparator was entacapone, the second generation. And these patients are followed up for a few weeks, usually 3 months. And at the end of the follow-up, there is a comparison, and what we call the primary outcome to document the efficacy in such cases is to measure using diaries how many hours during the wakened day the patients are off or on. And when you look at the 2 pivotal trials that have been conducted in hundreds of patients with Parkinson's disease suffering from motor fluctuation and treated according to this protocol, you can demonstrate that there is a difference between the groups, so that those who have been on placebo have a mild placebo response, some diminishing in the time spent off. But when you look at the cohort of patients that have been receiving the active drug, opicapone, then the reduction is significantly greater, by about a little bit more than 1 hour. So you could say with the placebo response, you have 1 hour less out of the 5 hours at baseline. And when you look at the cohort on opicapone, you get this 1 hour of placebo response plus an extra hour of benefit, which is related to the activity of the compound. And 1 hour reduction in time spent off is considered as a limit to be clinically important on everyday life of the patients. Now, there has been also in one of these studies, a third of the patients who have been randomized to entacapone, which is the older COMT inhibitor. Both entacapone and opicapone in that study proved to be superior to placebo. They have been shown also to be non-inferior between opicapone and entacapone. But when you look at the data, it seems that there is some extra benefit on those of opicapone, which in clinical practice as a group might not be seen as very important, something like 20 minutes, which is not reaching the threshold for the 1 hour of minimal clinical important difference, but overall might be seen as a greater benefit, or maybe also might be in some patient better response with this drug as opposed to the comparator. The other aspect of these trials have to look at safety and tolerability. And in the past, there have been major concerns regarding a rare but severe side effect, which is related to liver toxicity, and that has been reported with tolcapone, to a point that post-marketing, there have been few cases of severe hepatitis, which dramatically limited the way we can use tolcapone to a point that it is restricted to patients who are not responding sufficiently well to other alternative like entacapone in this time, and requires a strict liver enzyme monitoring, which doesn't make it very easy on everyday life. The entacapone is not demonstrating any special signal regarding liver toxicity, and opicapone is on the same good aspect of the new COMT inhibitors. This being said, and we already addressed that, with a COMT inhibitor, one is improving the bioavailability of levodopa, and so it is expected to translate into a better motor efficacy, but also slightly increasing the risk of what we call the dopaminergic adverse events. And you already mentioned that for dyskinesia, this can be monitored in everyday practice by adjusting the dose of levodopa, but it's not surprising, and this is a generic observation for any dopaminergic medication. When you adjunct these compounds to levodopa, sometimes gastrointestinal problems or neuropsychiatric problems might occur or worsen in some patients, and people should be aware of that. But overall, in the trials, there has not been major differences between the placebo, between the active arms, which means that, of course, it's a limited duration of follow-up. It's a limited number of patients, so you cannot pretend describing everything that can happen in real life in practice, but that showed that this is really not a major concern and manageable in clinical practice.
Particularly since you mentioned the gastrointestinal side effects, there have been, setting aside the dopaminergic problems like nausea or even vomiting, there have been concerns always with the previous COMT inhibitors like tolcapone and entacapone about a certain small percentage of patients who did not tolerate these drugs because of diarrhea. Mechanisms still somewhat poorly understood, and this, I understand, is different with opicapone.
Opicapone has not been reported as inducing diarrhea, as this is more commonly observed with entacapone, and there are some patients who cannot tolerate the drug. The proportion is, not entirely well known, but about 5% of the patient might have to stop it. Of course, this is going to be post-marketing, analysis, because even if it's hundreds of patients for few weeks of follow-up in trial, then showing a difference is out of the scope of this methodology.
Yeah, may not be the final answer, I agree. I think we in the limits of time that we are operating in, we must conclude our discussion, but I think we've had a good overview of the fact that levodopa continues to be the gold standard of symptomatic efficacy in Parkinson's disease after these many years, but has this important limitation related to its peripheral pharmacokinetics, although there are central elements, as you've pointed out, Olivier, and that luckily we have instruments, pharmacological instruments, to deal with those peripheral shortcomings, if we can call it that, of levodopa, and this is, for example, adding COMT inhibitors to prolong half-life and increase area under the curve, and thus enhance symptomatic efficacy on function in patients, and particularly on duration and cutting back off time. And by manipulating the dose of levodopa or other agents, we might, in case there is some increase in dyskinesia with this approach, we might deal with that and control for that. Opicapone is the latest on the list of COMT inhibitors which we have available, and you've highlighted, Olivier, that there is solid trial evidence to its efficacy, that it is probably slightly more potent than entacapone, although the trials were not built to clearly demonstrate that, but you alluded to the numerical increase in on-time prolongation that we've seen in those programs. And so it's another way, COMT inhibition, to make the best out of the gold standard of levodopa. So thank you both, and thank you, the audience, for being with us.